Smiley faces on, ladies and gentlemen. Very good. Yeah.
We want that.
Okay, let's kick off.
Yes, I do.
Welcome to the North West London Acute Provider Collaborative Board in Common public meeting. The last one for the collaborative before we become a group on the 1st of April. It's an emotional moment for all of us, I think.
I'm feeling very emotional.
I can tell. Welcome to members of the public who have joined us online and in the room. You're all most welcome. As ever, we will have a section at the end of the agenda for questions from the public. I've had some submitted in writing. I will also take questions from people raising their hands in the room or online and allow some time for questions at the end. And as ever, questions that we don't get time to answer, we will reply to in writing. And just to note that this meeting is recorded for the purposes of minute taking. So by joining the meeting, you are giving us permission to record your words, and if you have your camera on, to record the inside of your house. So I have a few apologies. Apologies from Benita. Apologies from Laura. Apologies from Lisa Knight. Are there any other apologies? Much. I have some Neds joining us online, and some of the executive online and others in the room. And I'm delighted that we are joined by Barbara Cleaver, who we will be coming to shortly, who will be giving us the staff story, talking about the London Ambulance Service triage service, which she is involved in making happen shortly. So, do we have any declarations of interest that people need to raise, or any items of Bob?
Yeah, I have registered this, but it's just to remind colleagues that I am, of course, on the ambulance service for when we have the staff story item.
Thank you for that, Bob. Any other declarations of interest? Thank you very much. Let me move us on to the minutes of the meeting, which I assume, Catherine, you were going to say you were at that one as well, so we will correct that. Are there any other corrections to the minutes? Thank you very much indeed. And you have the log. Are there any matters arising from the minutes, or any matters on the action log that anybody wants to raise in the meeting? Oh, good, excellent, thank you. In which case, we can move on to the staff story and welcome Barbara to the meeting. She's going to talk to us a bit. Barbara is an emergency medicines consultant at Imperial, and Barbara, you're going to talk a bit about the triage hub, I think, and how that's working, and then we're going to open it up for discussion, and I think we would be extremely interested in what you can say. So tell us a little bit about yourself, and then tell us and then talk to us about the triage.
Very much, Matthew, and thank you very much for inviting me to talk today about the staff story, which also involves patients. My name's Barbara Cleaver. I'm an emergency medicine consultant. I work at St Mary's, where I'm also a trauma team leader, and Charing Cross emergency departments, and have a 25-year history of working in EDs across North West London. I know that everybody here in this meeting is really committed to tackling the global problem of overcrowding in our emergency departments. And actually also there's surges of attendances of patients that could actually be better served in other healthcare settings. So North West London, I think, has been quite unique in the country in setting up a regional-wide integrated care coordination hub, which is too much of a mouthful, so I'm going to call it the London Ambulance Service Hub. And it's based in Pinner. And what's unique about it is it brings together multidisciplinary, clinical, experienced expertise to patients in a pre-hospital environment with the aim of trying to reduce conveyances to hospital and actually manage patients safely and expertly in their own homes. I want to tell you a little bit about what it's like working in the hub. So it's based in Pinner in Rayners Lane. It's like a little office. It's about half the size of this room with lots of tables set up. And it's really using some digital enabling technology to help us manage this patient cohort. So we utilise London Ambulance Services Cleric, which is their patient electronic system, but also the emergency department consultants working in the hub alongside GPs and advanced paramedics are able to access Cerner. And I'm sure you're all aware that Cerner is our North West London acute provider collaborative patient electronic system, which really works well because one can cross-reference patients and be able to really see what their acute care story has been. This also links in to the London Care Record, which is fantastic. So we're able to see every bit of the patient footprint. We also use the Good Sam app, that's Professor Mark Wilson's digital app, which enables us to provide video consultation to patients and also to crews via mobile phones, which is excellent, very easy for our patients to use. So how it works is you go in as an emergency medicine consultant, introduce yourself to the team. And it's important to say that the emergency medicine consultants are coming from emergency departments all over North West London. I think what's really important about that, it's creating this idea of polyculture. Any of you that are gardeners in the room will know how important that is to biodiversity in terms of actually sharing ideas, understanding what's happening in each of the unique emergency departments that we have in our region, sharing ideas, and more importantly, sharing decision making. So when we arrive there, we're able to see the stack. So that's the whole of North West London's ambulance calls. Those are calls from 999 from patients and also from 111 who are asking London Ambulance Service to attend. So we can filter them into regions of North West London, but generally we're looking at the whole of North West London rather than the regions that you might be serving, for example, in your own emergency department. We're then able to see them by category. So category 1 to 4 ambulances, and obviously that's dependent on the time response for London Ambulance Service. We then have a little look and interrogate the system as to why a patient might have called London Ambulance Service or why a healthcare professional or 111 may have asked for an ambulance to attend. And we intervene where we think it's appropriate for us to see a patient. And I've listed here, if you'll just bear with me for a second, a number of patients that we're really trying to enable. So frailty patients come first. Anyone that's had a fall in their home, anyone that's in a nursing home, anyone that's potentially on an end of life pathway. And of course, we're able to see universal care plans that might have been set up by GPs and actually really utilise that information, speak to the patients and their families directly, or speak to the crews, taking advantage of the fact that they have some physiological observations for the patients, and we're able to see the patient to be able to guide them as to whether or not it's appropriate to keep them at home. And as I say, the video consultation really enables that for sort of safe decision making. Nice going on outside. So there's a couple of other patients where this really does work, and that is that we're able to actually book people into same-day emergency care. All of our 7 emergency departments have got same-day emergency care. Some of them have got a focus on frailty. I'm thinking specifically about the West Middlesex here, that's done a fantastic job with their frailty service and their same-day emergency care and being able to integrate that, and also AMUs. So let's just take a frail patient as an example. If the family are enabling that person to be able to get to hospital and they need it, I will be able to contact the same-day emergency care department and actually allow those patients to make their own way there in a scheduled appointment, which may actually even be the following day. And the reason why that's important is because in the evening, all EDs in the sector are creating a massive surge in attendances. We want to try and even out that surge and utilise the SDEC capabilities that we have in the morning. So other ways in which SDEC can be used, and from a personal experience here, there was a patient that I spoke to, we were able to video consult. She'd had a flu-like illness. She had bilateral pleuritic chest pain, so pain really sore when she was breathing in, bit of a cough. Actually, when you drill into the history, she'd had pneumonia as a child. She was very worried that she had pneumonia. Her GP had prescribed her some antibiotics and she'd just finished the course. She'd been asked to call 999 from 111 because she had chest pain and had gone through the chest pain algorithm. Actually, her pain did not sound cardiac. The crew were there on scene. I was able to determine that she didn't have an oxygen need, that her physiological observations were normal. I actually booked her into our own SDEC at St Mary's, where I knew I was going to be the next day, which was great because I could follow up her care. And we did a chest x-ray when she arrived the following day, which looked clean. We just slightly broadened out the spectrum of her antibiotics and she went home very happy to have not attended an emergency department that evening where she'd have had a long wait to see somebody, and it was a scheduled appointment. She had a cup of tea in our lovely SDEC and everybody was happy, and it was good to be able to reassure her with some diagnostics which did not need to happen that evening. On the same day, and this was last week by the way, there was a 91-year-old patient, and we'd actually asked the crews to call the hub for some advice. I was able to see on Cerner that he'd been recently discharged from Charing Cross Hospital under the care of urology, and he'd had urostomy tubes put in. So they're little tubes where they drain the kidneys but come out onto the surface. And now he'd gone home a couple of days before the call and had been called by rapid response team who'd gone out to see that there was a bit of blood in the urostomy tubes. Now, the rapid response team are probably not that used to dealing with patients with urostomies, and quite understandably, they had called an ambulance to take this patient to hospital to see a urologist. I think what we could have done is looked at what was in the contents of those urostomy tubes and actually reassured that team that the blood was not a problem and actually quite a common experience once those tubes are placed. Sadly, what happened is this patient landed in the emergency department. He's 91. He unfortunately waited in our corridor all night and went home the next day, which was a really poor experience for a 91-year-old, and we could have really intervened that. And I think that those are 2 good examples of where we can actually do something pre-hospitally that enables us to reduce the denominator of patients coming into our ED only where it's appropriate and only where it's safe. The other patient cohort that I think is really key for this is our high intensity use patients, who are high intensity use patients for numerous reasons, many of which are healthcare anxiety, many of which are chronic problems, many of which are low level in between primary and secondary care mental health problems. We reinforce those patients and their behaviours by continually conveying them. And of course, for our ambulance crews, they have less visibility of. So they're less able to see, for example, that patient might have been seen in an emergency department just the day before. So enabling that patient to have a careful, thoughtful, kind conversation with a senior clinician really helps them and the crews to not convey. So it's been a great experience working there. We're early in our journey. To give you an example of numbers, last week when I was there, we managed to prevent 41 patients. That's me and a consultant colleague from London North West. We managed to prevent 41 patients from coming across the sector. There's lots of opportunities to make this go even further. Digital prescribing would be one. Enabling rapid response, for example, to contact specialties directly, utilising a follow-up clinic, which one of the orthopaedic surgeons at Imperial sent, to be able to digitally put people into SDEC. The great thing about that is the patients get a lovely text message explaining where to go, what time their appointment is, and all of the instructions, and also the same day emergency care does that too. So that trusted assessment, which I think people feel safe with when it's a senior decision maker, an emergency medicine consultant that's really got some skin in the game of trying to actually make sure that patients who don't need to be in our emergency departments are managed safely elsewhere. I think that's all I'm going to say now. Questions. Thank you.
Just here we are. So I think we're in now.
Okay, great.
Ask the people who are online to put their microphones on mute. Thank you very much. Okay, that's brilliant. Thank you very, very much. All right, open up the questions. And Martin.
Thank you. That was really interesting and a great service. I have a question. Is this A&E managing something that primary care should be delivering in the first instance? Or is it something that emergency medicine consultants are particularly suited to? In other words, if everything worked beautifully, would this service be something that you guys should be running, or should it sit in primary care?
Thank you, Martin. That's a really excellent question. I think it's actually about primary care and emergency medicine working in collaboration. So there are certain cases, and I think remember that primary care closes, it's not open 24/7, and the emergency department is. So quite a lot of the calls to the hub are actually from GPs, perhaps GPs visiting nursing homes, perhaps GPs concerned about patients that have called them. We're a broad church, but we've got two very different skill sets. The emergency department is excellent at providing timely, forgive me if I'm teaching you to suck eggs here, Martin, but timely, crucial investigations. And I think what we can do is potentially look at those people that may or may not need those urgent investigations that night, that evening. Could it wait perhaps till tomorrow morning? Could we flatten out those surges in attendance? So I think that's where we can work really well and collaboratively and share some of our workload without actually placing undue risk on either sector. Does that make sense?
Thank you very much.
Thank you. Roger.
Just to build on what Martin was saying, I think one of the key bits that you've been demonstrating is the balancing of risk appetites, and risk appetites are very different from primary care and emergency department. But the other key bit I wanted to just ask a little bit of additional information on is that we've got different models. Okay, you've talked a lot about SDEC, same day emergency care. But the other thing that we've developed over recent years is the virtual ward as well. Do you want to talk a little bit about how that is crucial to underpin the work that you're doing?
So we were talking about this just in the break, weren't we, Roger? So we've got a number of virtual wards. And I think what's kind of a bit more tricky in the hub and what we've got some work to do is underpinning the different types of virtual wards that each of the acute provider collaborators are involved with. So we need to kind of really link with them, but also make sure that these are working hours scenarios. So be able to really communicate with the leads for those virtual wards on that day. The disaster is to send somebody to a virtual ward only for the virtual ward to bring that person back to the emergency department, because actually that's a terrible patient experience and a poor waste of resource, really. The diabetes virtual ward would be a really good example of this. I've just recently been diagnosed with diabetes and I've suddenly upskilled myself. But with digital technology like continuous glucose meters and pumps, etc., there's a great way in which we can actually promote the diabetes virtual ward to enable people to go directly there, because there are so many digital enablers for people with both type 1 and type 2 diabetes. Same with COPD, although I would argue with COPD and asthma that actually you need the crew to go out because you really want those physiological observations. And that's not a loss if the crew goes out and you can make a then clear decision based on the physiological observations that they are then totally meeting the criteria for the virtual wards. I think it's great. We've got more work to do on that, but it's really important to get that done. And some of that work will be each of the acute providers telling the hub what they can and can't do with their virtual wards and the way in which we can access them digitally.
Very good. I'll take a couple more comments. Pippa?
Thanks,
Oh,
Barbara.
sorry. No, sorry. Julian, I mustn't cut out the former National Clinical Director for Emergency Care. He wasn't.
No, thank you, Matthew, and thank you, Barbara. And just a more response to Martin's question, because I think this is all a really good example of where neighbourhood health, as a practical example, helps support patients in the community, how we work together with that left shift emphasis to provide this sort of service. So I think it's a really good example of that, and I think something that we should be applauding. Thank you.
I just wanted to come in on that actually. So we're very lucky in North West London. We've got fantastic rapid response teams, really skilled community matrons. A lot of this work is actually enabling emergency medicine consultants to connect with the community in a way that I think we've never previously done. We've always worked in silo. Coming back to the polyculture again, we really are learning much more by working there, by actually communicating and spending a day with other clinicians that work in different fields. We are upskilling our knowledge and taking it back to each individual emergency department. I think that there's just that in itself has a lot of scope to generate more ideas about how this can work even for patients.
Pippa?
Thanks. I agree with all. It's great. We need to do more of it. 2 questions. So have we got consultants from all 4 of our trusts working collaboratively? Because there's a benefit of bringing you all together absolutely as well. And secondly, have we now got our mental health colleagues in there? Because I'm really keen that they should prevent conveyance for mental health patients to A&Es and try and put them to time, but that would need mental health professionals.
So those are 2 really pertinent questions. The answer is that Imperial and London North West at the moment are the 2 trusts that are providing emergency medicine consultants. That time is coming out of EM consultants' own time. So it's not being remunerated off their rota. And actually, I would argue that this sort of work lends itself to not every single emergency medicine consultant. It's a self-selecting group that really are keen to take some positive risk. I think that's not a good way of phrasing it, but actually really reach out to patients and make sure that we're getting patients in the right place, but actually utilising our resource and not like filling the emergency departments out of hours. Of course, the service benefits all of the EDs, because when you're working there, if somebody lives right next to Heathrow, for example, you're not going to try and sell them over to Hillingdon Emergency Department. So actually it's benefiting all EDs. I think we would all love to see colleagues from Chelsea and Westminster, West Mid and Hillingdon Trust join us. I know that there's been some early conversations, particularly with the Hillingdon, around utilising their fantastic new SDEC, which is run by their emergency department, and being able to reach into that and for the hub to directly refer. So yes, I think that's really important. Coming back to mental health, at the moment, the ambulance service have got very specific mental health crews that are going out to the very obvious mental health attends, or for where the police have called. And I'm sure you're all aware that there is some interesting work both in London and nationally around Right Care, Right Person, and the police wanting to convey more using the Mental Capacity Act rather than the Section 136. So there's a bit of complexity around that. As somebody who's got a very vested interest in acute mental health care crisis, I'm itching to get at those calls. But at the moment, I think that we need to build up gradually. I think one solution around that will be to enable our MCASs And for the emergency departments with co-located mental health trusts, there's certainly scope in avoiding the emergency department and going straight in there, provided you can provide clear certainty around physical health, which might be quite difficult to do in a pre-hospital setting. But if you've got a co-located mental health trust, why wouldn't the emergency department go there rather than the patient come to the ED? So you could think about reversing the way in which we do things for patient benefit.
I'm going to take Leslie, Saeed, and then Tim, and then I'm going to come back to you, Barbara, for a last word. So Leslie.
Quickly. So I think we've got to be fairly forensic as well about the impact. So it was good about Barbara, that the patients that you diverged the other day. So being clear about how many of those patients do have, in particular nursing homes and parallels, do have a universal described, because many of them still don't. And then actually, what does that tell us about what we would have to put in place in the nursing home or in the community, like IV antibiotics, all of those things that would stop those patients, that once we know that once we admit them, they stay for a very long period of time. So I think there is some great work to be done, and great work being done, actually, but we need to build on that. We need to build on it consistently.
Great thing about this.
Barbara, can I ask you to wrap all up at the end? Saeed.
Thank you. This is excellent to hear. Now, I'm sort of challenged by two thoughts. Are we that unique in Northwest London? Are these problems potentially similar across the country? If we were to be more collaborative in our thinking, not just as an acute provider collaborator, but also working with our primary care trust, and that this model could really be successful as an implemented model. And there's more evidence coming from the junior doctor strikes, because we've seen increasing evidence that healthcare outcomes and waiting times, etc., are reduced by senior colleagues from ED being present. So knowing that this works and having corroborative evidence, could this not be scaled? What more evidence do we need to make this happen across the collaborative, perhaps across the country? Thank you.
Tim.
Thanks, Barbara. Really good examples. I guess I went to a meeting last night where we were discussing, amongst other things, the fact that NHS has a bad case of pilotitis, which is that we roll out a pilot, which seems to have some sort of impact, but then we aren't able then to scale it. And I suppose the question for me is, do we have a really rigorous mechanism for assessing the effectiveness of this? And then how do we scale it? How do we have the conversation with LAS? Should we be having more of these hubs? How does it link into 111? Because we know that there are still an awful lot of people who are coming to hospital by ambulance that don't need anything done. So it's about, it's 41 is fantastic for one person in one shift. But of course, in the course of a day, it's a drop in the ocean across the numbers that are coming to our ED. So I think the key thing is, what can we do to support you in demonstrating this is the right thing to do? We know that Steve has got a 2.5% hived off as money to help the left shift, and we should be helping you to make the case if we can demonstrate, and we genuinely believe this is the right way to go forward.
So, wrap us up.
3 points. First of all, there's a great deal of governance around this. There was a pilot for this in the summer. So this is kind of the first few months of a new service. So the pilot went through stringent governance. Every single one of the cases is recorded and followed up to look at the outcome. So speaking to your universal care plan as an example, Leslie, if we notice that somebody doesn't, that's an instant letter to that person's GP to say, we need one, thank you very much. So every single case goes back into a pool where it's fed back and looked at expertly, and we are going to be iterating and learning from those cases where perhaps we made the wrong decision. And of course, we will make the wrong decision. We absolutely need to scale it up. We need to scale it up, I think, by having potentially hubs in each of the sectors. Now that takes away from the sort of polyculture of learning from one another, but of course we all know what our hospitals do well and how we can make most efficiencies if people do need to come to ESTEC or the ED by making direct referrals, for example. And also we know our GPs locally, so we're able to connect with them in a better way. So I think scaling it up means instead of having something central, having sort of 4 areas within Northwest London. It definitely comes from a national model. Julian might be able to correct me, but I don't think anywhere in London is doing it as a sector. And I think what's unique about London is we've got in our area 7 emergency departments, plus for our boundaries, you know, the Royal Free, University College Hospital. So there's the potential, and I know London Ambulance Service are keen to move into NSL and try and get that going there. I see that there's a lot of benefit in that because patients don't respect our nice, neat 4 quarters. But to reassure the board in common that there is a stringent governance process, there's weekly learning, and I think this has great potential to scope up. Out of hours in particular, I'd like to see it work up until 10 midnight in the evening.
Thank you, Barbara. Thank you so much for your time and coming to us. That's fascinating, brilliant work, and let's hope we can prove it and scale it and make it a key part of the how do we keep people who don't need to be in an A&E department, have an A&E department. It's better for them and it's better for us. So thank you so much for your time. Well, that was so riveting, I could run on for a bit. Moving on to the less riveting, let's move to my chair's report. You have it in writing. I just wanted to draw attention to 2 things. First of all, and most importantly, this is the last board meeting for 4 of our NEDs who are reaching the end of their 6-year terms of office. And I just wanted to extend the forward thanks to them for their general enormous contribution, but also the very specific things that each of them have brought. Amand Delvey has chaired the audit committee at Chelsea with rigour and scrutiny, but also I think has his long experience on capital programmes has given us an additional sense on where problems might lie and how to avoid them. So thank you so much for that. AJ Mehta, AJ has led the people program, but also I think has driven across the collaborative a lot of the work that we've done on diversity, and we're grateful to you for that leadership that you've offered over the years. Linda has led on quality at Hillingdon and has been tenacious in driving many of the issues that we've needed to surface and then resolve, and has been vitally important there, but also I think has been a role model for NEDs in terms of boots on the ground, getting out, talking to frontline staff and being connected with what's happened in the hospital. And Simon, whilst getting over the problem of being the top supporter, has led the people agenda, and has also, I think, provided a great deal of leadership and insight as the strategic direction for Hillingdon has grown, and the capital programme and the new building has evolved. So to all 4 of them, thank you so much for what you've done for us over the last 6 years, and you will be missed, and I'm sure you will go on and do equally great contributions in other areas after this. So thank you so much. Thank you. I'd also like to note that this is Sim's first meeting as the new Vice Chair for Imperial, and extend my thanks to Paul, who has just stepped down as Vice Chair, but is with us for a few more months on the board as a non-executive, and I will try and think of something nice to say about you by the time we get to that. It's going to be a harder task. So welcome, Sim, and thank you so much. Bob, we will be moving on to talk about the governance arrangements for the new group, but it is just worth noting that part of what is going on now is that we are reducing the total number of non-executives on the board. And the upshot of that is that we've had to do a bit of a shuffling around of who is sitting on what board in order to get the numbers right at each trust. And so you can see in there the shuffling around, and that is where the foundation trusts have been involved. We've taken that through the councils of governors, and where the non-foundation trusts are involved, we have had that's all been approved by NHS England. The other things in my report we're going to talk about in more depth as we move through the agenda. I'll move you on. You can to 2.2. You can also see the summary of the board in common cabinet. The cabinet meets to pick up things that need to be dealt with in between board meetings, and specifically there we went into in some detail the first draft of the business plans, which will be on the agenda later for more detailed discussion. And with that, I think I can throw this across to Peter to take us through the governance arrangements for the new provider group, which we will be moving into from the 1st of April.
Thanks, Matthew. Thanks, everybody, and particular thanks as I present this to Dawn, who we worked closely together on developing these governance arrangements. So this is a product of a number of conversations we previously had at a board here, stretching back to October actually, and then November we had another session. So I preface this by an apology for the amount of paperwork that's in here, but these are the governance documents that will help us set up the governance model for the group from the 1st of April. So I'll go through the different bits of the paper, but you'll see in here we've got an update on the board composition, the scheme of delegated authority, the terms of reference for the group and local committees, and the memorandum of understanding. So first of all, in terms of the board composition, you'll see in the paper that following the conversations we've had at previous board meetings around what kind of board do we need to support the governance model, Matthew's just mentioned the work we've done on the non-exec side of the boards. We've also been working our way through the legal constraints around board composition, and you'll see in the paper we've settled on the proposed executive composition. And as we discussed earlier on, there will now be a nominations and remuneration committee, hopefully in the next week, that will approve the recruitment process for these posts. So then if we go in into the specific the governance documents that you've got in front of you. The scheme of delegated authority, you'll remember that when as a collaborative, we developed this scheme of delegated authority, which provides the delegation of authority from this board to the various committees that we have as part of our governance model. So this is a build on what you've previously seen as part of the collaborative, but will obviously removes the local board committees that we previously had, and instead delegates the authority to the new group committees that we have established. In support of that scheme of delegated authority, we then have the terms of reference that we've developed for each of the committees. These draft terms of reference have been socialised outside of this meeting, and we've had very helpfully one or two comments in there. So finance and performance, and thanks to particularly to Virginia, who spotted that we haven't actually included in the terms of reference the decision-making duty of the finance and performance. So we will add that in. So we'll seek approval subject to those amendments to those various things. We recognise that we haven't yet got a terms of reference for the strategy committee. We'll work with to develop that. And we've got an audit chairs meeting in the next few weeks where we will go through with the 4 audit chairs the proposed terms of reference for each of the local audit committees, so that we can standardise those across the 4 trusts. So then the next stage, if we approve those terms of reference today, is that where there's more work to do then in terms of translating these terms of reference into forward plans and business cycles that we will go through with the chairs of each of those meetings and the lead executives, so that we've got a rhythm and we've got a cycle of business that will support what we need to do going forward. And then finally, you'll see in the package is the group memorandum of understanding. And again, you'll remember that when we set up the collaborative, we developed a memorandum of understanding. It's important, I think, to note that the memorandum of understanding is not a legal agreement for the group. This sets out some basic principles on which we want to work as we work together. Previously worked together as a collaborative, and now that we will work together as a group. So they don't set out any kind of binding agreement between us in terms of finance or anything else. These are about the principles on which we want to work as a group. These have been developed, obviously building on the previous version that we had as a collaborative. So, as of for today, I think in order to start the committee cycle and the governance model from the 1st of April, seeking approval for, in particular, the scheme of delegated authority and the terms of reference, so we can establish those committees and to then agree the memorandum of understanding as a starting point for the group.
Thank you very much, Peter. Let me open that up for questions or comments. Kevin.
A very minor point. I think it's an oversight, Peter, but I think the group medical director lead would be on their people committee, because the CMO, the lead CMO, is not mentioned in any bit of the terms of reference. So I think we were planning that it would be the lead CNO and the lead CMO that would be there with the group chief people officer. I think that's just an oversight.
There's as we've developed the terms of reference for these committees, obviously the key principle of the group committees or any committees is they are non-exec majority going forward. So we've then worked out which of the execs need to be there in terms of membership, but also recognising that there are a number of executives that will be in regular attendance to these meetings. So again, I think we will probably iterate these as we go forward and we develop and mature these committees, but it's a fair point.
Thank you. Tim.
Yes, thanks, Matthew. And just to note, the details not in these papers, but just to note that I will go back through the reporting lines for the proposed 2 new posts to make sure that they are logical and clear as they can be before it goes to the preparation committee, after feedback from my non-executive colleagues.
Questions or comments? Yeah, Adrian.
Yeah, clearly, this is good and clearly quite complex in terms of what they're doing it. It was just a comment on the NED champions. I think it's really helpful to have clear role descriptions for those roles, because actually they're not new roles, a lot of them. So, but I think it would be helpful to make sure that the roles are clear, that there are resources in place, access to networks and support, and actually how what the interface is really with how they can add value in terms of the executive functions, and actually so there's no overlap, etc. So what does champion really mean?
Thank you. Dawn, did you want to come in on that?
Please, yeah, thank you. And thank you, AJ. And you're absolutely right. And we, just to assure you that we have actually developed that piece of work now. We haven't yet socialised it, but we do have role descriptions for each of those traditional champion roles that we have, but also we've done some role descriptions around the lead NED role and what the expectations are of the lead NED role that we're establishing as part of the group governance. So you should get to see those shortly.
Yeah, I mean, just a piece of feedback from the joint executive group last week, which is that it's probably helpful to try and have a sort of lead NED role and a champion role as opposed to just champion, because we've got champions for maternity and various other things that are sort of statutory, and these are slightly different roles. So just to distinguish between those 2 roles.
Oh, good. Any more questions, comments? Please, Catherine.
Just to follow from earlier conversations, where would you see research and education role and committee fitting within this structure?
So at the moment, I think it would fit into quality. I think that we will work out that, as we've had a previous discussion about, where once we've got an executive committee set up where that best reports it. Strategy could be, the trouble is strategies are task and finish, I think, so.
Is it?
That's what caution is a perfect setup. You could argue, for example, that you could go into education, could go into people.
Yeah,
so you know there are different places you could put things. So I think there's a thing that says we need to just make sure, and I think this does, how we report things now, and out of that will come actually this doesn't fit very neatly, and therefore we're going to move it to wherever. And in a way, that's what makes life interesting, isn't it?
And we should, so I don't think it's said out loud, note the overall commitment to not increase our management costs at the end of this process.
So I should just note on Leslie's point, we've always committed that this will be the starting point in terms of getting the group up. We, as per the collaborative, we commit to reviewing this on a regular basis, more formally after a year, and then we'll come back and review whether this is effective. We may want to make those changes if it's not.
Any other? In which case, can I ask for agreement, first of all, to the scheme of delegation? Any objections? No. Memorandum of understanding. Thank you. And the terms of reference. Thank you very much. Thank you. Thank you for that, Peter. I will move us on now to the integrated quality and performance report and jump straight into the quality part of that. And Pippa, do you want to lead?
Thank you. So I'll take you to the performance summary page because it's the best place to see it all in one place. So 119 of the full pack. We've got some excellent quality metrics that we can see here. No real concerns actually that I don't think the board should be concerned about. We've got some assurance in maternity around the crude stillbirth rates still being lower than the national average. Obviously, we need to be careful of peaks and trends in month, but lower than the national average. And we've got some excellent mortality data with 4 out of the 4 trusts for their shimmy data being expected or better than, and VTE risk assessments being compliant as well. Not forgetting experience, we've got good patient experience feedback in all of the sites for inpatients, also for ED above trajectory, maternity just slightly lower than trajectory. It's an in-month dip for both Chelsea and Hillingdon, and both them sites are working through that, but nothing really of concern. The biggest area that we had the most focus on, I think it's fair to say, and the right conversation is around infection prevention control. It's a national picture. We've seen an increase in it in all of our sites. I'm not going to go into it detail here because you've got a full report on that coming, but otherwise there's some high-level summaries.
Thank you very much. Can I open it up for questions, comments? Anyone want to add? Oh, sorry, Lloyd. Yes, thank you.
Thanks. Pippa, the IPC situation looked particularly concerning, and all 3 organisms also have a relationship with hand hygiene. What have we found so far that you're able to share today?
It'll probably be best covered off, Lloyd, if you'd rather, in the IPC report that's come in, because our actions are all documented in that report. So should we cover that?
So Julian's was in the 415. Thank you. Right. Any other questions on the quality of this? It was nice to note significantly more things pointing upwards than downwards this quarter. It's taken a while to get to that place, but well done. Thank you. Let's move on to the report from the Elective Orthopaedic Centre. Mark.
Thanks very much. Mark Tickham, the Managing Director of the Centre, and also joining the meeting is Matt Bartlett, the Medical Director, who will help answer any questions or add any comments. So a couple of points of clarification from the report, page 177 of the pack. Now in its 2nd year of operation, so 18 months running at full capability. There's a couple of areas that I particularly choose to highlight. Firstly, the impact on the overall waiting list for trauma and orthopaedics across the sector. We can see the contribution that the Elective Orthopaedic Centre is making alongside the activity that is also undertaken in the home trusts and the decrease in the overall waiting lists. And we're showing it there split by trust as well. and also to highlight in particular, the clinical outcomes and specifically probably the length of stay, which is now sort of set and being maintained at the GIRF standard of 2.3 days, and it's been at that level now for around about a year. So I think that's good in terms of it regularly and continually achieving that length of stay. We've had a second external review. So the GIRF team led by Tim Briggs came back in November of last year for their 1 year on review, and we've included some headlines from that. And we've also included in the report the lessons identified and some of the learning, which we showed here about 8 months ago, but we've repeated here just to recognise that in particular, as we move forward with potentially the development of other shared services or indeed other collaborative pathways, clinical pathways across the group. I just wanted to mention about sort of next steps and in particular the focus on activity and next year's operating plan. We specifically are looking to address the imbalance that we've got at the moment in terms of activity between London North West and the other 3 partners. So that sort of split. Currently, that's around 75% of London North West activity and around about 25% comes from partners, and that's some way off what we intended and what was in the original business case, which was much closer to a 50-50 split in terms of activity. So 2 areas that we particularly want to focus on to address that. One is a sort of forensic review of the pre-op assessment process. So we review that model. We're currently trialling a slightly different approach with one of the trusts, and we'll need to adjust that model moving forward. And secondly, we'll need to continue to progress the pooling of patients. And we've made progress in this area in terms of consultants from one trust operating on patients from another trust. There's some examples within the paper, but we'll need to continue to do that to ensure that the patients that sit under consultants who don't routinely come to the elective orthopaedic centre are treated and have access in an equitable way. So those are the 2 areas to particularly focus on addressing that imbalance. And then in terms of the final point is really around continuing to deliver that what I would call is a cultural shift in terms of how we manage patients across the sector, so that further movement effectively from what has been in the past sort of siloed working to that more collaborative and joined up approach across the trusts, and we feel we're on that journey and on that path at the moment. I'll stop there, Chair, but very happy to take comments and questions.
Thanks, Mark. Excellent. Can I open that for comments and questions? Nick?
Yeah, thanks, Mark. That's a really helpful report. Just one question that I had in the context of what you're talking about rebalancing between the 4 trusts. What is total capacity? How much more can you take, as it were, without taking away from London North West to add to the others? I mean, is it balancing or is it just increasing overall activity to increase from the other 3 trusts? Just understanding the total capacity of the unit.
Thanks, Nick. Yes, it's a bit of both. So we've got the ability to increase the capacity or the activity through the centre as a whole. We're currently doing around about 3,300. We've increased by 7% this year on year 1. But if we remember, the original business case came through this board in common 2 years ago. That had a figure of around about 4,000. So we've got a little bit further to go to achieve that level of activity. We've got the capacity to do that. And next year, we won't have such a constraint in terms of the financial side, which has been quite tricky this year in terms of the elective recovery fund. And we've had to work that piece through. And then within that, we need to rebalance, as I've described, in terms of making sure that we've got the right number of patients coming through from the partners and London North West, while also taking account of the overall waiting list and where the long waiting patients are across the sector.
Thank you. Tim?
Sorry, I'm sure I should have asked this question before, and you could when you were talking. You were talking about pooling of patients and starting to surgeons from some trusts operating on patients from other trusts. Do we already have working very effectively consultants from the same trust working on patients from other consultants of the same trust? Because in my head, once you've overcome that, you should there should be no basic difference between that and pooling across trusts.
We do. Shall I ask Matt to come in on that specific?
Yeah.
Yeah, I can take that. It varies across trusts. So we've got formal prospective pooling from within Hillingdon that works very well. We've got a slightly less formal system within London North West, which is functional. That works well with surgeons taking patients from other surgeons. The systems seem to be less well developed within Imperial and Chelsea, but they're both working towards that. That's certainly our experience within the context of the EOC. So I don't have any direct experience outside that of the work that's going on at the Home Trust. But this is one of the sort of the cultural shifts that we need. We're making progress on it, but we really do need to shift towards pooling both within the trust and or also between trusts, really, to make the most effective use of our surgical resource for our patients.
Thank you. Sim.
Thank you. Thanks, Mark. Just in terms of the lessons learned, which are really useful, that achieving fully shared involvement and ownership. Notice that the surgical leads were identified early, but the anaesthetists weren't. In another life, what would we have done differently, not just from a timing, but the way we communicated with our consultants to kind of win their hearts and minds to get over this sharing of lists? Is there anything to be done going forward that we can take with us for other projects?
Thanks. I think we had a change of as we developed and mobilised the model from business case through to opening. I think we had a change in approach regarding the role of the anaesthetists with the original thinking that they would effectively withdraw an anaesthetist from across the 4 trusts. And then I think as we began to develop the model and understand the complexity of having consultants from effectively 4 trusts, but 8 or 9 hospitals working through a single centre, we opted for the approach of London North West providing the anaesthetists. And I think in terms of running the centre, it is complex already, but it would be very, very complex if we were to attempt to do that. So I think that was the right decision in terms of making that modification. But it has meant an additional requirement resource effectively for London North West to make sure that they are able to provide those anaesthetists. So I think there's some learning there in terms of how we had to adapt as we went through the process. I would say that some of our colleagues do actually provide 1 or 2 anaesthetists to support the centre, which is really, really welcome. And Matt may just want to add something on that.
Matt?
Yeah, I think it's a brilliant question. I mean, from my perspective, we'd probably want to move a bit earlier on proper sort of cooperation and sharing out of the workload earlier on in the patient pathway around POA. That's starting to happen more and more now and has been really helpful. And also the same as the surgical side of things, sort of trying to sort of move away from that siloed working and having groups of anaesthetists in each of the trusts, actually establishing a bond of trust with each other so that decisions taken in one trust are not questioned in another, because there's no doubt that everybody is competent and working in the best interest of their patients.
Last question point, David.
Yeah, thanks. So Mark, Matt, thank you to you and the team. It really is a very encouraging development that's going on at the EOC. And clearly, once the rebalancing and some of these lessons learned have been captured and improved upon, directionally, this is absolutely the right way to go. I mean, to pool resources, to have centres of excellence, patient satisfaction, getting it right first time. So despite some of the hurdles, it's directionally, it must be the right way to go, and you should be congratulated on the journey so far.
Thank you. And thank you, Mark, and thank you, Matt, for coming to us and for the work that's going on. So very much. I'm going to move us on now and ask John to introduce the Learning from Deaths paper for Q2.
Thank you, Chair. So as Pippa said already, relative risk.
We've lost you, John. You gone?
Sorry, I seem to freeze for a second there. I'll start again. Can you hear me okay now, Chair? Perfect, great. As Pippa said, relative risk shimmy and HSMR remain lower than expected or as expected, and that's for the period through to June 25, which you've got in the packs. The two trusts, London North West and Hillingdon, where they were slightly higher than the other two trusts, both of those organisations do a secondary review looking at diagnostic groups that have flagged, and clinicians go over those cases to look for any care issues, and reassuringly none were found in those groups. We also continue across the APC to do level 2 reviews, which is where clinicians again go into cases that have triggered on a set of triggers that we use and review those, and if there's any concerns they get fed into the appropriate governance groups in each organisation, and that looks for suboptimal care that may have contributed to deaths, and that the range sort of percentage wise of any potential suboptimal care ranges from about 0.29% of all our deaths to 0.39% of deaths across all the trusts. So in summary, I think mortality remains low across all the organisations. The piece of work that we're working on at the moment is the continued alignment of the kind of secondary review of the deaths. We have slightly different triggers for the level 2 reviews that I mentioned earlier, and in mortality group at the moment we're looking at syncing those up so you can have slightly clearer comparisons when looking through those. And that's the summary of the report. Thanks, Chair.
Great, thank you. Thank you, John. And lower than expected is a good thing. That means fewer people are dying predicted by the case mix we have. Joining us. Any questions or comments for John? I know this has been gone through in some detail, both the quality committees and the standing committees. Any other points that people need to raise? Okay, thank you very much, John. Let's just move on to the annual safeguarding report. And Janice, over to you.
Yeah, thank you very much, and thanks to my CNO colleagues, Jess over there to my right, for pulling this report together. It's a summary report or annual report of the individual organisations and covers 24-25. And your individual trusts will be published on your website. There's a lot in this summary, and quality committees and trust standing committees have reviewed the annual report to be able to create this summary. Three main areas really. I think overall in 24-25, and from my own experience that's continued in 25-26, the activity levels are up both across particularly adults but also in children, referrals and management of safeguarding issues. There's a big training challenge, I think, across safeguarding generally. I'll come in a bit more detail in a moment, but the training requirements are ever increasing, and we're all grappling with the Oliver McGowan implementation of phase 2 of that training. At Imperial, we had a CQC visit, admittedly in 25, but there were some criticisms of the levels of training we had at adult level 3. And that actually, if you scratch the surface across trusts within England, is probably a broader issue. And we've shared already some of that learning with trusts within our APC. And we're moving towards standardising our adult, certainly our adult safeguarding level 3, and Imperial will get that pretty quickly. I think it's fair to say, from the CQC perspective, that despite that comment made about our adult level 3 safeguarding, that knew about safeguarding, were able to raise awareness and knew what to do if they had a safeguard. We're also waiting on training outputs of the National Training Board that the Imperial Chief Executive chairs, and we anticipate that there'll be some rationalisation of children and adult at levels 1 and 2, and then some further guidance around prevent and levels 3. So it's a bit of a changing picture. And the third comment I've got is that there's quite a big opportunity for us to share good practice across each of the organisations and build on the good practice that we've each individually got. And I think as we move forward off the back of the training and the increases in activity levels, we'll find ourselves working much, much closer together to standardise what we're doing and to bring out and share the good practice from each of the individual organisations. I'll stop there. I could go on, but I'm happy to take any questions.
Thank you, Janice. Let me take Carolyn's question.
Yeah, so thank you, Janice, and thank you to everybody who's doing all the work on this. To see the increased level of referrals, I think, is not a worry. I think it's a real positive. So, so thanks for that. I am concerned, though, about training issues and what is determined to be mandatory training and what is not determined to be mandatory training. And I just wonder whether there's anything we should be suggesting to the centre about this to better simplify it. I mean, have to have level 1, 2 and 3. Why don't we just have one level that incorporates it all? For example, the NED training that we do on safeguarding is like so basic, it's nigh on insulting, frankly. So I don't understand why we can't just have one lot of training. I personally really enjoyed the first level of the Oliver McGowan training. I thought it was good. It was less patronising, frankly, and it was more impactful. But I do think it just all needs sorting out because it's no wonder we are not achieving our targets.
I know you someone with some influence.
Yeah, I'm kind of looking to someone who's got my hand up to that problem over to Tim.
So completely agree with you. So I chair the National Statutory Mandatory Training. Sure.
I'll let you all follow.
So our aim is to try and improve and rationalise this, and we are absolutely looking at this. And so there is an intercollegiate document that has guided what's been done recently. I am hopeful that by the end of this calendar year, there will across the country be a rationalisation of this training. I agree with you. It seems unduly segmented into multiple parts, and I think there's an issue about how Prevent can also be taken account of in this training. So watch this space.
Is that in your appraisal?
And to be clear, Tim, you've only taken that over in the last 6-9 months, haven't you? You're not responsible for the last 8 years.
I'm not responsible for. Thank you for emphasising. Yes.
I think it's. I mean, I think the awareness. You're right. It's really important, and the referrals is a good thing. But I think the training's grown up a little bit.
Yes.
Chaotically alongside. The increasing issues in our society generally around mental health, ageing population, and therefore domestic violence, few campaign and safeguarding coming alongside. So I think it is right for a review and a kind of rationalisation. And I'm sure once we've got the guidance, the next step with some of Kevin's colleagues, Sue Grange in particular, and I know she's shared what we're doing with Hillingdon and Chell with Rob and with Sarah at Chell West and Hillingdon. The 4 of us will need to work together really to take forward a combined approach and pool resources, pool expertise, to make sure that the staff that need to be trained get trained at the right level. And increasingly, I think more of us will need to complete the level 3. Our clinicians generally complete the level 3, which absolves you of the need to do 1, 2. There is a Prevent level 3 that I think increasingly more of us will need to do as well. So it's kind of we'll bring something back collectively, either as part of the 25-26 annual report, separate paper through our standing committees, and then back here.
Yeah.
Thank you for that, Janice. Saeed.
Thank you. I just wonder how much evidence is there, whether, nationally, as to the effectiveness of this training. Does the training make a difference to patients? Thank you.
Yeah, I'll let Tim come in a minute because we both feel quite strongly about this, I think, but there's not a lot of evidence that very much training on its own has much effect on the individual and the outcome. There is a hierarchy of interventions that particularly are used in health and safety, and it's making sure that the workflows, the electronic record and the policies and procedures along alongside training, standardized practice. So we are all doing the right thing all of the time. And when those things come together, it works. If it's just training on its own, you can't be sure of the effectiveness. And when I've looked at the evidence, the research and evidence base, it's flimsy, but I'll hand over to Tim to comment.
Well, I'm very impressed. I completely agree with everything you said. The only thing I would add is I think that it's very difficult to now work out what impact training is currently having because we didn't have a baseline before training. Similarly, if we make any changes, obviously all we'll be able to do is to work out all the differences between having the old training and the new training, not the new training. I think, but it's a surprisingly evidence-free zone.
It's training has two purposes. One is to teach people stuff they didn't know, and the other is to raise the priority within the culture of an organisation that something is important. And it probably has at least as much impact on the second, making people go through the training as it has on the first.
Many of the ways we practice is a little bit of theory and then experience in practice, but in most of the clinical profession.
Well, just to try and be a bit more upbeat. If we just look at the number of safeguarding referrals, that is a positive thing, as Caroline said. That is our staff identifying a potential child or adult at risk. They have to understand safeguarding to be able to identify them and make the right referral. So you could read into that the training is having a positive impact. The extent of the training and sitting in a room for a day is questionable. But actually, you would take some positive away from it because we have got an increase in identification and therefore the right safeguarding nets.
Tim, last point, and I'm going to move us on. Thank you. That's a good point. Thank you very much. Thank you for that, Jazz. Let me move on to Julian and the Infection Prevention and Control Annual Report.
Thank you, Chair. So this is the annual report for 2024 to 2025 with the more up-to-date IPC information in the dashboard. So it's important to sort of read them across. The report is based on effectively the different infections that we need to control, and each trust is given a threshold each year by NHSE as to what they need to get below in terms of the number of infections in different areas that they have. And when you achieve that target, then they bring that target down each year. So it's a moving thing to improve how we respond to infection control. So each hospital, each trust across the country has a different threshold. If we look at the report for the 24-25, we can see that none of our trusts achieved the thresholds for both C. difficile and MRSA. The MRSA is a 0 threshold, and you can see the varying thresholds for the C. diff. 2 of our trusts achieved our threshold for the E. coli infections, and their subsequent have had reductions made in their thresholds for next year as a result of that, but the 2 didn't. So this is disappointing that we haven't made those thresholds, and it's an important area of healthcare. So we are an outlier in comparison to various trusts. We're certainly not best in class around this as a result of that, but it is an area that we've been concentrating on. Joy asked us the question about what are we really trying to do around that. Well, it is sometimes the basics that we need to do, and the mainstay of this is hand hygiene around MRSA, but also to do how we screen, how we isolate, how we eradicate and suppress once we find cases of this for MRSA. And for C. diff, it's very much to do with antibiotic stewardship as well as screening. So those are the 2 things for those 2. And for E. coli, it's very much often working with the whole system and not just the hospital is important here as well, because although we're looking at the hospital rates here, there are also rates within the community for all these infections at the same time. Some examples of sort of good practice. I turn myself back to Imperial and the hand hygiene. So we use a slightly different methodology using the methodology from the WHO, the World Health Organization, which is an independently assessed rate of hand hygiene compliance. And we were down at sort of 40% when we started that work, and we're now up to above 75%. And remembering that for WHO, 75 is excellent and good is at 65% because of the robustness of the methodology they use. And now that's learning that we are producing across to all the other trusts at the same time. And there's learning from each of them that we need to do, but there's also learning that we need to take from the best in class around the country, where we can benchmark against those and learn what they're doing to try and improve those situations as we go through this year and the following year as well. I'm happy to take any questions.
Thank you, Julian. Again, we've taken this through our quality and understanding committees, but any questions to be raised here or any additions that anyone needs to make?
Just quickly, mate. Julian, thanks very much. If one looks at trend data, so rather than this particular report for this particular year, are you concerned that there's a worsening trend of some of these infections, or is it really more about this particular year was a bit of a bump for us?
So I think in terms of trends, I mean, the one which is always difficult is MRSA because it's very low numbers. So looking at trends, it tends to go up and down a little bit. If we look at the trend of something, and it's in the graphs within the board report, if we look at E. coli infections, we can see both nationally and locally and in London, we're seeing a reduction in E. coli infections, which is good. And that's, I think, due to the work that's going across the whole of both the pre-hospital, the out of hospital and the hospital work that's going on. I think there are trends, unfortunately, at a national level and at a London level, looking at C. diff rates where they're actually slightly on the way up at the moment, and we need to bulk that trend and bring them down.
Thank you. You want to come in on that, Tim?
Yeah, just I think generally the numbers of hospital-acquired infections students said are actually going down. The issue is that if you do well, your target is then reduced more stringent, so you then have to do even better. So you can continue to improve year on year and still be missing the target.
Thank you. I'll take two more points and then I'm going to move. So Lloyd, then Said.
Thank you. Julian, does our EPR support the early detection of infections and try and sort of measure how quickly infection control teams intervene to stop the spread? Do we have any metrics around that? Because that is going to take us to the next step of quality, isn't it? Being quick at the detection and intervention.
Yeah, so Lloyd, I think there's a difference here between sepsis, where there's a real urgency to get on top of those sepsis, and these where very often this is to do with screening, and then how do we suppress, and then how do we isolate those patients quickly as well once we identify them. So it's a slight difference. And yes, there is a lot of work going on to try and make sure that what we do with screening is the same as others who may be doing better in class. And are we doing enough or too much screening? Where are we sitting in that? But it is important that we do need to isolate patients with these infections very rapidly as well. And there's an education program, especially around C. diff. How do you recognize it even before you get the results back, so you're isolating the correct patients for the right infections?
Thank you. And Said.
Thank you, Gillian. As you've alluded to, and the evidence supports that good or strong antimicrobial stewardship and IPC rates are linked. Now, the best of the organizations, both nationally and internationally, are those who have very strong antibiotic stewardship programs supported by perhaps their electronic records and asking, is this patient still requiring antibiotics, etc., or people going around doing that. And I note in our report that the antibiotic stewardship is pretty, we're all doing something, but there's no alignment in it. And comparison of what measures are happening, and also anything happening with our community partners, because that's where you can capture E. coli, etc. So yeah. I'd have loved to have some more detail there. Thank you.
No, thank you. And if I start your second question first and then go back to your first one, there's a lot of work going on around things like E. coli and how we work between the community and the hospital trust. And very often these are related to catheters and how we manage catheters across those organisations. And I think that you can see that both in the London, the national and our own data in terms of reducing numbers of infections occurring from those. And that's a really good thing and makes a huge difference to patients. In terms of antibiotic stewardship, you're absolutely correct. And as I mentioned before, that is a really important part, especially with things like in the shorter term C. diff infections and the longer term MRSA and everything as well, because you want to reduce the antiviral resistance itself. And that, I think this is the work that we need to go through now. This is the work that we're doing now as a collaborative to look at how we make sure that our policies are aligned. And are we learning from each other as best, but also national and international comparators, so that we're trying to take up the best of best. But absolutely, antibiotic stewardship is a really important aspect of this.
Thank you. I want to move us on. No, is it?
No, well, just on that side. So we are just implementing an IT system that does that. It's a bespoke system that does antimicrobial stewardship. It's in place at Chelsea and Hillingdon at the moment. It's coming into London North West, and Imperial have got a very similar system. So we'll all be streamlined.
Excellent. Thank you. Thank you, Julian. I'm going to move us on and Rob to the maternity incentive scheme.
Yeah, thank you. So the paper just provides the self-assessed position for the 4 trusts for year end for year 7 of the maternity incentive scheme. This has come through APC Quality Committee and individual standing committees. At the end of December, all 4 trusts are forecasting full compliance against the 10 safety standards as outlined in year 7. Over the next 2 weeks, a period of peer review of the evidence against each of those standards will take place prior to the board declarations forms being submitted on the 3rd of April by individual provider chief execs. And then a confirmed position will be brought back through the Acute Provider Collaborative Quality Committee. No issues of risk or concern was escalated by any of the 4 trusts for the board in common or the APC Quality Committee.
Thank you. Thanks for that, Rob. So to note, this is a report that's going on the 3rd of March. It's not a board submission, it's a chief executive submission. So it'll be signed off by chief executives. Now take questions, Carolyn.
Yes, please. Sorry, it's just a point of clarification. So I can see the 10 standards in Appendix 1, but the table just above that has 43 different items which are graded. And my assumption is that all 43 will be green at the point of submission. Is that correct?
Yeah, so apologies for the confusion in the paper. So the paper covers 2 elements. So the maternity incentive scheme, which is the first section in the appendix. The second section relates to the single delivery plan, which is a 3-year improvement programme for maternity and neonatal services as a result of the national reviews, which also has to be done by the end of the financial year. And the table that you referred to lists the current position at the end of September. That has improved since the time of this report. And all 4 trusts equally are forecasting full compliance against all of their standards by April, and that will also be brought back to the Quality Committee, but that isn't a requirement from the declaration or the Year 7 incentive scheme. They're 2 separate.
Thank you.
Thank you. Okay, thank you very much from that, Rob. I'm going to take that as noted and move us on to the annual health and safety report for noting. Kevin.
Yeah, as you say, Matthew, for noting, this has been to the Trust Health and Safety Committees about the individual trusts and the APC Quality Committee. Thanks to Dawn, who wrote the paper with colleagues from each of the 4 trusts. It provides an overview really of the different systems and processes. I think as we move forward, we'll be looking then at more of the collaboration and how we can do things together, as well as understanding the processes and systems in each of the trusts separately. That's all I want to say, really.
Thank you. So we've discussed in the local trust. Is there anything that anyone wants to raise or question? Okay, thank you very much for that, Kevin. And then finally in this section, but by no means least, Pat, the Quality Committee Chair's report.
Thank you. It's here for reading. We've actually covered many of the aspects and the points just before, because we've done the deep dive in infection prevention and control, which is the main aspect of discussion at the meeting. It was covered the performance report We've covered the issue about deteriorating patients and sepsis also in the last report, which hasn't been in this bit, but we did cover about aligning clinical pathways and best practice and looking for advancement. I think it's probably fair to say in the next year or so as we move the collaborative closer together. I think those are probably the only aspects really for updating from the committee, and then moving forward we've got the action plan for the next year, which we will be reviewing in light of the whole new collaborative structure coming together, and there's just been one quality report.
Thank you very much, Pat. Any questions or comments on that? Okay, thank you very much. That was a long quality session. Sorry, I missed that. Sorry, please.
Well, thank you. While the colleagues are doing their best, I still feel that the corridor care, or called temporary escalation spaces, it's not the best option for our patients, but it's the available option. And I think as a collaborate, as a group, we need to think of strategies to really come off from those areas. How do we do that?
Thanks, Said, and we would all agree with you. It's not the best option and we're all working hard to avoid it. But we do have to cope with winter demands and flu peaks. But I don't think this is particularly a group option. It is unique to each organisation, the estates, the layout. Some of it may impact the group, but the majority of this is working at local provider trust to be able to avoid it. We are all working hard. I can certainly talk to London North West. That is one of our three main objectives corporately this year, was to reduce our temporary escalation space. And we've just done some measures this week to change our flow and work to be able to do that, to improve that. So I think it's broadly something that's locally seen at quality committees at the moment. And I know our quality committee had a very good exposure to that, and I know the others did too.
We've discussed at the standing committee as well.
Yeah.
Okay, thank you. Thanks for raising that. Okay, I'm going to move us on to the people section, and Pippa, it's back to you.
Do you know what? I'll hand it straight to Kevin.
Okay, thank you. I mean, on the KPI side, we can see positives in terms of vacancies, turnover, and the temporary staffing usage, and doing pretty well against the staffing use against the overall plan, but mainly focusing on trying to keep to the financial balance forecast. So we have got some challenges about the staffing levels, but we're doing fantastically well on controlling the agency and bank, where we are hitting the national targets, I think, and core skills is still steady. Challenges, we've got challenges with sickness in all but one trust. We've got challenges on non-medical appraisals in a couple of the trusts, but we've got a plan for both of those in terms of the non-medical appraisals. And the biggest challenge for all of us consistently is about their goals and our progress, which is what the people committee have been having a lot of conversations about, is our progress towards getting a more diverse leadership within our hospitals. And so I think that those are the summary of what's in the QPR bit of the report.
Thank you. So any questions on the people section of the report? Yes, please, yes.
Sickness management and psychological is a challenge I think is important, because looking at some of the trends, they're not going in the direction we want. What's your timeline on tracking progress for the initiatives and how we can then implement change?
I think they're different in each of the trusts. Actually, I was having a conversation with a psychology lead at Hillingdon yesterday, where we were looking at what's happening in the different trusts and see how we can help with mental health. I don't think we necessarily agree of what we're looking to reduce from a mental health goals. I think what we're doing is creating a common set of strategies, which includes mental health support and what we can do for well-being, as well as things like sort of first aid, as well as how we engage psychological services. The trusts are different in terms of the level of support they have on the ground. If you take one extreme, we've got big counselling service in one trust, and we have sort of half a person working in another trust. So I think part of the group work is how can we use the resources that we've got more collaboratively, but I can't say we have a specific trajectory that I can point to get it a certain cause down, if that's
well, I think to bring resources together across the group would be really good, but also to assess whether the resources we're using are having an impact, and maybe looking more at root causes.
Yeah.
Thank you. Thank you. Leslie.
Yeah, I mean, I think there's a more fundamental question, to be honest, which is how do you prepare people for work? How do you prepare our trainees, be they nurse, particularly our clinical trainees, actually, the job that's there, and how you make them resilient? Because what we're ending up doing is starting talking about mental health. Of course, for a group of people, that would be absolutely appropriate. It's also something that says, what is the normal rough and tumble? Working or living and all of those things. And I think we're talking to the colleges actually about that as well, which is how do you do that preparation in a more fundamental way.
Thank you, Leslie. Very good. Can I move us on to the chair of the People Committee? And David, this will be your last one in this capacity.
Yeah, indeed. Just a couple of points. I mean, there is an awful lot of work going on in the people space, and I really want to commend the executives and teams for managing all that change, whether it's consultation processes, and a lot of this has been fed through to the people, and we just want to reiterate how good a job you're doing in that space. There are a couple of escalations I just need to bring to the board's attention. I touched on it slightly before, and this is around the effectiveness of the EDI action plan. There's a very good equity, diversity and inclusion plan, but how effective is it? How good are we at implementing it? So that's the piece we're keeping a close eye on. There's also a lot of work going on the recruitment hub model, how you standardise recruitment across the 4 trusts, and we're just, watching that to make sure that delivers as it should do and on time. And I think that's the biggest thing we're keeping an eye on, is this balance between the needing to get the right size organisation without having any negative impact on the patient experience. So it's like managing the numbers whilst ensuring the quality of service remains intact. But those are the only points, Chair, that I think I would add.
Thank you. Any questions for David or a question on this report? Okay, thank you very much. I will move us on to the finance and performance section. And Leslie, but first of all, just say I'd like to see that the equity scores that have been developed are now beginning to appear in the report. They're of course now going to create questions that we have to answer. So that is the point of measuring. I've seen that sort of reporting going on anywhere. So I think huge step forward and congratulations to the team.
Thank you. Well, I'll quickly hand over, but before I do, just to say that always we're slightly, in terms of our reporting, we're slightly behind, but just to say it has been very busy, not just in North West London, but across the country, and you've seen that play out. And we have tried really hard to do that balance between our elective recovery and our continuing to try very hard, and you'll hear about, and the balance of that with the emergency work. Very, very good stuff happening. And I am going to call out Hillingdon, which said at one stage they had the best ambulance handover in the country. So I think that was pretty impressive, actually. But I would say there's always more to do. One of the issues we've got now is that as we come into the final quarter of the year, we've just seen a big flow of money, which is tricky coming into our balance what we're going to do to try and use that money as productively as we can to treat more patients, but it's always difficult to plan that. It's come with good consent, but sometimes it's difficult when we've got to do that very, very quickly. It becomes an expensive way of care. That's my sort of overall summary. I'll hand over to James, actually.
Thank you, Leslie. So consistent with the changes that the board in common agreed to our scope of reporting, this report now includes the 31-day cancer standard, which reports as a collaborative both the national and London levels of performance, and we agreed to adjust the long waits in urgent and emergency care, the 12-hour standard, to type 1 performance only, and again that reports above both national and London level. The main report itself covers the November performance, save for cancer and maternity, which is October. The data has been validated and reviewed at the executive
board. As is consistent, each of the COOs or managing directors has a portfolio, and I'll turn to each of them to cover their specialist area of performance, starting with urgent and emergency care. Over to you, Sheena.
Thank you, James. Thank you, Chair. Afternoon, everyone. So just on the 4-hour performance for November, we landed at 76.9 against a target of 78%. That was up from the previous month, which is good given some of the challenges we've had. Also, just to let you all know that we are tracking just above the national average as well as the London average. But clearly more to do, as you can see in the slide. Some areas are more challenged than others. We are continuing to see discharge delays. That's also impacting the front door. So the daily oversight really is now at sort of director level and exec level. Most of you will be cited on sort of the continuous oversight we've got at the front door, and the focus really is on maintaining safety and delivering high quality care. On the 12-hour waits in ED, our performance is 8% on an allowance of 8.6%. So essentially, we have seen roughly the same as the previous month of 8% of all type 1 attendances over 12 hours. So a lot more to do there, but mental health remains a challenge for the sector, and we're seeing the overall impact of those long lengths of stays in ED. All trusts are focused on improving patient flow, not just at the front door, but throughout the hospital, and a range of actions to recover performance and maintain safe levels of care, including escalation processes are in place, and those have been enacted several times a day to maintain safety. There's a slide in there around sort of mental health 12-hour waits. You can see that our allowance is 24%, and we for November are tracking around 32.6%. All 4 acutes are struggling to meet this trajectory. We have escalations in place pretty much every day with our mental health colleagues within the sector, as well as out of the area sort of patients. So more to do here. The plan for reducing mental health waits for the system, there has been some mitigation. We've seen through the ICB and business planning some mental health assessment suites going in and being stepped up in Q4. We will hopefully see some impact, but it's obviously not a whole solution to this much bigger problem. That's all I was going to say, but happy to take questions. Back to you, James.
Thanks, Sheena.
James, first, before you do, sorry, can I just mind it by exception, if that's okay, because all of these have gone through quality and standard. Just on the mental health, because just to say we have had a meeting with London and with the new mental health lead, and then for London's Vanessa Ford. So there is a piece of work now being done for London, but for London, on how we do mitigate the mental health challenges.
Thank you. That's helpful. Yeah, I'd like to move on. I'll move on through the reports and then pick up any questions we've got at the end because we're a bit tight on time.
Okay. In Laura's absence, Alan's kindly going to give the update on elective care.
Yeah, thanks very much, James. Thanks, Chair. To be brief, looking at the RTT element, we remain stable for the 18-week target, which is we are performing as our standard, a little bit over. The compliance has been monitored at sector level, but also at trust level as well. There's been quite robust and comprehensive action plans for both London North West and Hillingdon, and we're tracking towards those. So we are pleased to report that we're at standard for the 18-week standard. Looking at the long waits, there is a continual improvement, although not yet at the standard that we are aiming for by March 26. We have internal trajectories to meet that requirement by March 26 for a 52-week performance. and there is, for the first time, there are 0 patients that are at the 78 weeks in November compared to the previous month, which we are pleased with. There's increased productivity and efficiency as part of the normal work that we're doing, but there's also been additional clinical activity that we have shared out amongst ourselves. It will come as no surprise that a great deal of our conversations has been about 2 areas. One, which is the NHSE validation sprints, but also in the clinical area of ENT. Thank you. Back to you, James.
Thanks, Alan. I'll cover the cancer performance. Pleased to report good performance in both the faster diagnosis standard, which has improved this month. This is set against a fall in both London and national performance. So we are on an upward and improvement trend. And indeed, it's great to see that all collaborative partners have achieved the faster diagnosis standard individually, not just as a collaborative. In terms of the 62-day performance, that remains a stretching and challenging target to hit the 85% standard. We are currently at 78.8%, so 79% overall. That's well above the 70% ask for London. And again, whilst we've seen static performance at both national and London level, we're bucking the trend with improving performance in that domain as well. Finally, I'll hand over to Ian to cover the diagnostic performance.
Thanks very much, James, and good afternoon, colleagues. So from a diagnostic perspective, performance sat at 21.7%, so that's access to a range of diagnostics within 6 weeks, and that is against a allowance of 5%. Positively, we've seen some improvement at a number of the trusts within the collaborative, and our performance is on an improving trend and is now in line with national performance and better than London performance. However, we recognise that there is a significant amount that we need to do more in order to bring that performance in line with national expectations, and the planning guidance for the next 3 years sets some even more challenging targets in that area. All trusts are working through what the demand capacity for diagnostics looks like as we go through the multi-year planning round. One of the important things to point out is one of the greatest challenges that we continue to have is in relation to equipment downtime. And the other thing that our organisations are working through is how the capital funding that has been put aside for diagnostics to return to constitutional standards can support us in part of that recovery moving forward. Back over to yourself, James.
Thanks. We're open for questions, Chair.
Any questions? We've been through this in our standing committees. Anything we need to raise here? Okay, thank you for those. Let's move on to the finance report. I think that's you, Bill.
Okay. November's position, so month 8, year-to-date performance deficit of million against the plan of a £3.7 million surplus. So that's a £8.1 million plan. Now, we at that point we would have had 2 industrial actions, one in July and one in November. Members had one in December, but that's will be in December's financial position. That's causing part of the adverse variance, because at that point we did have no funding for industrial action. As of month July, we have had some funding for all partners, and that'll be in month. The position is deficit of £3.5 million. Like I said, most of that is to do with industrial action. We have had some additional funding. I think Leslie agreed, said it earlier about to support our referral to treatment. We have £37 million in total over and above the plan. This helps achieve our elective targets, but obviously it's come at year in some instances, so it means that we're going to have to speed up our activity quickly, do this within the next few months. Efficiency delivery is adverse to plan by 13 million year to date. However, in month 8 we delivered 16.8, which is an increasing amount. So whilst we had that hockey stick effect, it is coming to fruition, and we've been delivering more and more each month as we've gone on. We talked about pay and some of the things that have happened in our pay. So agency as a percentage of is 0.6% in 25-26 compared to 2% in 24-25. So we've improved our reduced our number of agency staff in our organisations. Similarly, is 8% year to date compared to 10% in 24-25. You'll recall, as part of the board, we a large part of our cost improvement programme was to reduce our whole time equivalents. Comparing month 8, given that we also had industrial action month 8 this year compared to last year, we've still had a reduction in whole time equivalents of around 400 whole time equivalents, which is 1%. The largest reductions are at London North West and at Hillingdon in particular. The pack does include activity versus plan. Activity and against plan. Whilst it shows that we've got an underperformance against plan in ED attendances, actually we assumed at two trusts that we'd have a 5% increase in overall. So actually, on actuals basis, we have increased our activity in ED. Just against plan, it's slightly lower. The INE forecast at month 8 is still to break even, which is in the one thing that I should mention is the cash balances across the APC is 280 million, higher than 24 million higher than end of March, and 87 million above the cash plan for November. So we're maintaining good cash balances across the APC, and we have not had to go and get any cash support as an APC at this time. The lowest number of days is at London North West at 3.2 days. You'll also see that actually our better payment practice code in all areas is improving and increasing. Last thing I'll say is capital spend is 12 million underspent, mostly driven by some of the national programmes, but we will deliver to our plan, spend our capital as per.
Thank you. Any questions on the finance plan that we've not picked up locally? Okay, thank you very much. Can I move us on to the planning for the coming year and the 2 years after that? Is that you again, Bill, or is that?
Well, it's a combination of myself, Kevin, and James. So the report that you've got is summarises the kind of process that we undertook to develop and submit the APC provider trusts draft financial, operational, and workforce plans, which are signed off by the extraordinary board meeting on 17th of December and submitted on the same day, which was the national deadline. The final plans will be submitted on the 12th of February this year, and the paper summarises the governance route to the of the APC to agree and sign off plans ahead of that final submission. The first and final plan submissions were developed in accordance with the guidance that was received from NHS England in their medium-term financial plan framework around released in October. The full planning guidance was released on 17th November, which included IPB revenue allocation 26-27 and 27-28. So the third year of allocations hasn't yet been finished. Trust submitted 2-year revenue plans for ops, financial and a 4-year capital programme. We will have to submit a 3-year revenue plan and a 5-year capital programme in due course. In the appendice, you have the targets that are expected to be reached for each trust as per guidance. I'll take you through the financial planning approach, but James will then take you through ops and Kevin through the workforce. So the plans were set using forecasts for 25-26, and we adjusted for some non-recurrence that happened in the year, such as industrial action, and adjusted for future planning assumptions as per the national guidance. The overarching aim is to set an income and expenditure plan that reflects our resources and agreed activity and income contract plans. That includes our inflation assumptions, bank age trajectories, and cost improvement plan. Income and activity plans are based on draft contract allocations received from lead commissioner, which include funding streams received in 25-26 and any overperformance in 25-26 and income to cover the cost of meeting those constitutional standards, both unplanned, so A&E, and planned care like RTT and diagnostics of cancer. These are not yet contract offers. These are only allocations for the purposes of planning. We're awaiting contract offers from our proposed commissioner. Contract proposals have not yet been confirmed for NHS England, Specialised Commissioning, or any other non-North West London commissioners, with commissioners reflecting just our internal view of flat funding for those. Capital allocations per provider have been given to us at NHS England, and they are assumed in our planning. The next steps for planning in particular is to agree contracts, further work internally to review our financial plans, and in terms of capital, we need to work with the Commission and the London region around bidding for urgent emergency capital funding and our estate safety fund. I'll hand over to James to talk ops and then Kevin for workforce.
Yep, thanks, Bimal. So in operations, we have triangulated the expected performance standard as described in the National Operating Framework into a set of activity. We've costed that activity in terms of delivery to be as productive as we can and use our money wisely. And we've also triangulated that with workforce and headcount implications to make sure that we've got the right workforce to be able to deliver it. We then work that through on a set of income assumptions and work in harmony with both finance and workforce to make sure we've got our accurate numbers with good read across. In terms of working through the next steps, so there is more to do around finalising productivity improvements, which we expect to be in the range of 2%. We're going to be working through a data quality check so that we have consistent reporting for all of our numbers across the collaborative. And of course, we're always sharing and learning from one another's plans where innovation takes place or learning from service developments. This year, we look to configure those into our plans and cross-reference. In terms of the delivery of the standards, as you can see from the paper, we across the collaborative are planning to deliver all standards, save for the 15 standard, which we expect to remain a challenge across the collaborative. The UEC position, urgent and emergency care, we have mapped to expect zero growth in urgent and emergency care, and that remains a risk as we've seen fluctuating levels of growth across the collaborative, certainly not a reduction in the need for emergency care in North West London. So we have to map that in our forecast and our performance expectations. Similarly, we've seen some fairly significant rises in GP referral activity. So on the elective care side, we need to map those in. Fairly crucial for a 3-year planning round to make sure we've got a good grip of our performance, improving our standard in key waiting time metrics such as the 18-week standard, and indeed we can keep a tight grip of our waiting lists over the 3-year term. Key performance challenge areas we expect to foresee, as Ian mentioned, diagnostics. We need to be achieving 80%. We're currently at 78.3% across the APC with particular challenges at London, North West and Hillingdon, and has been mentioned both some workforce challenges in that area and ageing kit. That said, that we are part of a bidding round for capital investments for both new areas, renovation, hardware and new kit, including diagnostics, and we're working through prioritisation of those bids at North West London and collaborative level. At UEC level, whilst we think the 82% performance in A&E set against this year's expected 78% standard assessed in March will be delivered, we know that the 80% average across the year, which comes in next year, is more stretching because it means you've got to consistently deliver both across winter and summer or to moderate performance in those areas to achieve 80% on average. So that will be stretching given what I've said about increasing demand, high levels of London ambulance handovers and a need to continue to improve ambulance handover. Right thing to do for the patient, ensures the patient receives a quicker, more timely service at community level, but often can overload emergency departments, causing pressure for the 4-hour standard that we need to meet. And then finally, the 62-day performance standard will move to 80% next year, but we will still aspire to the 85% performance aspiration with our Cancer Alliance. All of that said, we do remain confident in the delivery of our plans and indeed the fairly granular level triangulation that we've done this year across workforce and finance. Hand over to Kevin.
3 quick things. The numbers are really going to be the mathematics of how many staff we can afford based on the activity and what that gives us financially. There's the targets around bank agency and sickness in terms of what we're expected to deliver. And then the third part is the strategies that we're looking to deploy from a short, medium to long term. So looking, for example, in the short term about our workforce design and how we agree what staffing numbers we need and the deployment through rostering and things like that, through to the longer term things. Estate reconfiguration, redesign of patient pathways, reconfiguration of services. So I think those are the key points from a workforce perspective.
Thank you. Thanks for that comprehensive update. We have spent as a board in this time talking through this and we'll continue to over the next couple of months. Any points that we Simon, please.
Just we talk about increased pressure, and in the papers there's talks about the redistribution of local authority finance from inner to outer London, and the impact on our ability to discharge from our hospitals is going to become under increasing pressure. If we don't get people out, we can't get people in, and it puts at risk all those wait times.
Yeah, do you want to just summarise what the question?
Yeah. So there is a national discussion at the moment about the movement of resourcing between many local authorities, actually, but for us between the inner authorities and the outer authorities. And the question was about will it impact on our discharges? It might. What we're targeting is the Better Care Fund monies to ensure that we can keep our discharges and the flow of our patients through. We're having a national discussion about it, Simon, to be honest. I'm the NHS national lead for this. There are some concerns, but there are ongoing discussions, and we will keep this board well informed about it.
Thank you. Any other questions or comments? Okay, in which case I will move us on. Thank you very much for that, Bill, James, Kevin, and at some point we will be bringing back a final business plan proposal to this board, hopefully. Moving on to the digital data report, you can see the points that we've raised for the board to note. There are no particular concerns. Worth just noting that the leadership team across the digital services have now been integrated across all 4 trusts, and there is a process going on at the moment to bring together the services further down so that we have a single digital team across the collaborative, and there's a lot of good work going on there.
Can I make a very quick comment? Just I have said in the committee which I sit on that I think, and I know there are so many other priorities that we look at that actually, given the importance of digital and data in the future, it would be good to be covered in a development day, because I don't think the general lay board understanding of the potential and what the opportunities are is as explicit as it might be. And given it's so important in terms of both our investments and the way we operate, it's something that I think we should include at some point in a development day. It's important to do.
Thanks for that, Nick. Yes, we will. We'll see where we can fit that in. Thank you. Okay, can I move on to the Estates Infrastructure and Sustainability Committee, Bob?
Thank you, Chair. Pardon me. I'm going to take it as sort of read. All I would say, I know David's comments about the Collaborative People Committee. This committee now feels like it's doing some business rather than talking about business. And the report, I hope, is self-explanatory, although I'll take questions if necessary. I would just like to emphasise a couple of things, and one of which relates to a couple of points that have come up earlier in this public session, and in fact plays to Nick's point that he's just made, is with the increasing focus on backlog maintenance at local and group level. And now that we know what capital availability is for the next 3 years, and it's not a hugely generous settlement,
we urged Peter and the governance team to make sure that the BAF identifies a new risk, which is going to be the extent to which medical equipment digitisation gets squeezed because of backlog maintenance priority. And that plays directly into the comments that were made earlier about the diagnostic performance challenge, and it plays directly into the comments that Nick's just made about what the opportunities for digitisation are. So we need to flag that big. I would suggest we need to flag that big time. And I would also just ask all local trust steering committees to keep a strong eye on local trust improvement plans around the access able work, because this is about helping navigation and access to across all of our sites, which is utterly consistent with the EDI action plan that we all agreed many months ago. There's been a great bit of work done, but I'm afraid it is now down to local TSCs to make sure that we're maximising the opportunity.
Thank you, Bob. That as noted. Thank you very much. And I will move us on to the Acute Provider Collaborative Executive Management Board summary. Tim, anything you want to raise from that?
Thanks, Matthew. I think the paper highlights that we talked about the things you might have expected to talk about before this meeting, which I think is reassuring. I guess there are two things just to highlight. I think there's some work for us to do around the FNP, and we had a discussion about that. I'm particularly interested in really clearly defining the smallish number of modules and apps for the FDP we want properly roll out across the collaborative. To reference my previous comment about pilotitis, I think we do need to make sure that we get what we decide to do out. I think one of the key ones, about the previous conversation we had, will be the ability to have a single PTL for strategies across the whole of the collaborative. So that's, I think, an important thing. And then just to note, the robotic surgery strategy is coming back next month, I hope. It's not quite complete, but we did look at the business case for robotic surgery at London North West and Imperial. And I guess we're pretty confident that we are nowhere near saturating the demand for robots at the moment across the collaborative. We're probably a bit behind, if anything. And by going in together, the trusts have probably managed to leverage the benefit of about £200,000 reduction in consumables. So I think that's a good result.
Thank you. I'll roll on into the Chief Executive reports. And Pippa, do you want to go first?
Yep, so just bear in mind this is now slightly out of date, but fair to comment that the CQC did an inspection of our emergency services across our 3 sites unannounced in July. It was actually the day we had the board meeting here. It was published in November. It was only a single site service inspection, so it could only turn one site to good, which it did. So it turned Central Middlesex to a good rating overall as a site, which is great. It's the first time that's had a good rating as a site. And it turned effective to good as well for Northwick and Ealing. Overall, both of them still being requires improvement, with a few actions we're working through with the CQC. We also had the GERF team in to do a accreditation of Central Middlesex site, and it's fully fledged now as a surgical centre for under the GERF standard, which is great. It means we can do broader things in there apart from just the EOC that we've got in there. So it allows us to play out the strategy one might want to play. At this time period, the NOF rating we were 36 out of 130. Just remember, it changes every quarter, and this was the first quarter, so this put us into quarter 2. And I think everything else I'm covered. I'm not going to cover operational money because we've covered it, and I'm happy to take the rest of the paper as read.
Thank you. Let me take 3 reports and then I'll take questions before Pippa expires on us. Leslie, do you want to do Hillingdon and Chelsea?
So Hillingdon, I want to say well done to my colleagues. Actually, I think there's been a lot of improvement across all domains. Actually, it's still a heck of a lot to do, but a real feeling of sense of pride in that organisation, which is really good to see. And you will see we've described that, and we've described the outcome, which has taken quite a long time to come from the CQC as well. And then in Chelsea, Chelsea's both NOF ratings are now. Chelsea's has gone up to 1 now, which was good to see. Again, a lot of work over. Oh, it's failing to load my file. Never mind. A lot of work that we've seen, but actually still more to do. You will see in there the reference to look at the orthopaedic work done by one of the orthopaedic surgeons, which has hit the national press in terms of the work that he has done at Great Ormond Street. We have completed our review. That review has gone through our governance processes through Quality Committee and Standing Committee. 2 patients with one with moderate and one with severe harm, both notified. So we have come to the end of that. So not good at all for those patients, and some learning across the sector. That governance, you remember, was led under the leadership of London, actually, NHS England, London, and so all of the providers involved have shared the learning.
Thank you. Tim.
Thanks, Beth. We were pleased, I think, to continue. I think we were pleased to stay in the top segment of the National Oversight Framework. Be pleased to be second for non-specialist acute, the top teaching trust in the country. I should add that the vagaries of the NOF means, I think, you would be a very brave person to predict that you were going to stay in those positions. But I think to stay in segment 1, I think is good. I think the capability assessments have been published, he says.
Tomorrow.
In which case, I can those. It's not bad news anyway. I can't believe it's going to be last Friday. Anyway. I'll skip quickly on then. We had an unannounced CQC visit on the 16th of October to Charing Cross after 2 serious incidents on that was published. I'm pleased to say that the overall output from that was good, and Charing Cross Hospital is rated as good, which I think is good news. I think, as Janice has described, it has given us pause to really think carefully about our safeguarding training and how we make sure that everyone is equipped to do the job. Having said that, as Janice also mentioned, the report does highlight the fact that every single person they spoke to knew exactly how to raise safeguarding issues. Otherwise, I'm really pleased that Julian has agreed to step in to the role of interim trust level chief executive for ICHT starting in April. He remains at the moment the national clinical director for urgent emergency care, which is a small task. I'm hoping that over the course of the next 2 or 3 months, we will be able to perhaps a bit of a gentle handover. You can see a couple of operational highlights. I do reflect a load of really hard work from the team. So we had 0 patients waiting 65 weeks for treatment at the end of December, which was really, really good work. And that was a result of a lot of people's person marking individual patient pathways to make sure that people got treatment. Really pleased to see that significant improvement in the diagnostic performance, particularly in imaging, where we were having issues with MRI and ultrasound. I think that is it is really encouraging. One other thing I was going to say was slip my mind, so I should skip on. It's rather important. Ian Bateman is our chief operating officer in the last since the last board meeting, and we're delighted that he has taken that on. I just wanted to highlight some of the equality, diversity, and inclusion work. Particularly, I think the recruitment process with the letters, the chief executive. I mean, I do think of from below 40% to 48% improvement in the recruitment of leaders from Black, Asian, and minority ethnic backgrounds is a good and steady increase. I mean, I would like it to be faster than it's been, but I do think it has been a helpful intervention. And then finally, Pleasingly, from a research perspective, we've recruited 12,285 participants into NIHR portfolio studies. That's the 6th highest in the country. You will have seen the publicity about the Transform study, which Hash Ahmed had a £42 million grant for in terms of prostate cancer. Aligned to the BRC, we have now a GP commercial research development centre, which is being set up also by the NIHR. It'd be really interesting to see how that can work with London North West's clinical research development centre more widely. Imperial Health Knowledge Bank has now got over 140 patients who've agreed to be contacted for research, and I think you can see the list of other stuff from a research perspective, but it plays to Kath's point earlier. The task for us now is to get that out across the whole of the collaborative and make this a really exciting academic health science system. Final thing is that the execs will be moving out of the bays towards the end of February to the 5th floor of Salton House, so I will miss the view of the canal through the bars in my office windows, and I suspect that the four-legged creatures that also occupy the with us will also miss us when we've gone. However, the good news is that is so that we can get going for a Fleming Centre, which we're hoping will start construction towards the end of the year, with an opening in 2028. Finally, congratulations to Philip Bloom, who is the surgeon oculist to the King. He was awarded an LVO in the New Year's Honours list. Neil Poulter, who runs the International Centre for Circulatory Health, who was given an MBE, and Dominic Allwood, who is the Chief Executive of ICHP and also a public health consultant at the Trust, who also got an MBE.
Very good. Thank you very much. Any questions for the Chief Executives? Okay. Thank you very much for that. Thank you. I would just note, everybody's mentioned the NOF scores and Tim's warning to not overly predict the future, but the Q2 results that have come out have put all of our trusts in the top half of major acute hospitals, 3 out of 4 of them in the top quarter, and given us the 2nd and 4th highest performing acute hospitals in the country, which I think is a pretty damn impressive performance. Thank you.
And also the improvement at Hillingdon, I think, is equally impressive.
Yeah, he's outstanding.
Yeah, thank you.
Okay, I'm going to, well, do we have any other business? Nobody's given me any in advance. Any other business? Anyone wants to?
Are we going to take the standing committee reports?
Standing committee reports, isn't it?
There's a Chelsea and Westminster there, but everything's already been said at all the other papers in the Chelsea and Westminster one.
Oh, sorry, I skipped over. Sorry, they were slid in. You're absolutely, yes, thank you for the beautifully put question. Let me pick up. So first of all, any updates from London North West? Standing committee.
Well, I'd just add or emphasise the focus on the temporary escalation spaces, so corridor care, if you will. It's a concern we've had for a while, it's a concern we will share, and it's therefore getting the focus that it should be getting. So that's the only emphasis I have.
Thank you very much indeed. Thank you. Hillingdon?
Yeah, I just wanted to raise, I think I might have raised it before. Every standing committee we have, we invite Keith Spencer, who is the local Hillingdon-based ICB Director of Health and Care Partners, to our standing committee. We have a whole discussion about the left shift. What we do know is that there is a reduction in urgent admissions. There is an increase in speed of discharge, and there is an improvement in flow. But what we don't know, I don't think, generally across everything, is what specific interventions cause that. I think that's something we need to be discussing. It's a very good Barbara Cleaver raised earlier today as well. I think we need to be discussing that as an APC, not just as individual trusts as well. So
thank you. Yeah. Imperial. Oh. Tim, sorry. Tim's first one. Tim, anything to add from the standing committee?
No, I think just Bob's comment about estates. So that's the main issue for Imperial. So we need to watch that estates issue. Thank you
very much. And Pat,
I've got nothing to add. It's already been covered in the previous updates we've done.
brilliant. Thank you very much indeed. It's safe that we can close the formal part of the meeting. All right, excellent. In which case, I'll close the formal part of the meeting and move on to questions. I have 13 questions from the Brent Voices campaign. Thank you. We will take. I will take a couple of those, then I will open it up to any hands that are raised or on screen or in the room, and we will see what we get through in the next 20 minutes. So, Robin, let me come to you. Do you want to pick your favourite one of these questions? We will, of course, answer them all in writing if we don't pick them up here. Robin.
Thank you, Chair. We appreciate all the very good work being done by the trusts in the collaborative and the openness of these proceedings. But can I say, and I pay tribute to my colleague who can't be here, Gaynor, who worked till 3 in the morning to put together the questions in writing. But I'd like to ask a point that hasn't been raised, as far as I know, in the meeting, in relation to the enhanced collaborative, which has been agreed earlier. I don't know what you want to call it, but the present title is not very easy on the tongue. But if I was reporting to my PPG, what could I say are the main benefits to patients from this enhanced level of collaboration and the fact there will be a single chief executive? I mean, the fact that we know the chief executive and we know he'll bring a great contribution, that's fine, but it's very difficult to spell out, you know, what the achievements, what the benefits will be from this further collaboration. Thank you. Should I leave it at that for the moment, or do you want me to ask?
And I will invite Tim to share his thoughts.
Thank you, Robin. So so it's a very good question. So I think there's a couple of things, and the question obviously talks about people travelling around the sector and the time it takes them. I agree that it takes 80 minutes to get to Birmingham by train from London, but actually you still have to get from where you live to the station in London, which probably could add you another 80 minutes onto that. I think the benefits, though, are only partially about moving services together, and certainly the Elective Orthopaedic Centre, which we've discussed today, has really enhanced quality for patients as well as improving waiting time. So there's been something about that sort of level of consolidation. There's also something about by using money and resources more effectively, we can divert that money to patient care. Small example, obviously, the savings we will have made with the robotic surgery contract. I think we've already, for example, in the people and OD function and in the digital function, by having a single team, have managed to save some money and put money back into care. There's also, of course, the work that's been done on the pathway, the clinical pathways already, which I think have demonstrated some really quite significant improvements. So, for example, if you take a particular type of treatment, say for prostate cancer, we have managed to roll that out across the whole of Northwest London through the collaborative. But in addition to that, because we knew that there was inequality and inequity of vision, we were able to reduce the waiting list, which was particularly long at the West Middlesex, down to a point where we've equalised that out, improved it for everybody, and have been able to deliver that treatment. We've got other things that will make a big difference. So, for example, Al Myers, one of the surgeons at Hillingdon, has been leading on the work on ColoFit across the sector. That will allow us to interpret stool tests for bowel cancer in a different way. It will allow us to rule out bowel cancer for patients without necessarily having to have a colonoscopy. and it will therefore reduce the number of colonoscopies that we do, which will mean that the waits for everybody else improve. And I think I've picked 2 or 3. I could have picked 10 or 15 and bored you and everybody else. So there are real clinical benefits. There are real sort of efficiency benefits, I think, and we hope that building on the relationships, building on the work we've done over the last 3.5 years, we can then sort of turbocharge some of those. And I think that we will really be looking to make sure that we are standardizing our pathways, that we are identifying what best practice looks like and delivering that, really looking at the way that our back office functions are working and making sure that they are supporting the delivery of clinical care and making sure that the offer to everybody in North West London is consistent.
Thank you, Tim. Thank you. James Greeley, can I come to you for a question?
Thank you, Chair. Earlier on, I was very impressed by the report on the new orthopaedic centre about the large number of people being treated there, with better to come. When the business case was originally put together, the centre was contrasted with more complex cases, often but not exclusively of older people in home hospitals. Could you tell us what effect on waiting lists for more complicated cases has the new centre had in terms of waiting times of treatments and discharge for the other grouping of more complex people?
So, Matt.
Thanks, Malma.
Matt, are you still on as our clinical director?
Yes, certainly. That's a bit of a difficult question because we don't have direct sight of the waiting list for specifically for more complex cases at Home Trust, but we know that by doing more cases at the EOC, we have freed up space and resource at all of the partner trusts at their acute sites for doing the more complex cases, and we've seen a general reduction in the number of people on the waiting list and waiting times. So I would expect it to have done so, but I'm afraid I lack specific figures on the exact numbers that have been treated in lieu of other less complicated patients, shall we say, being treated at the Home Trust. Does that answer your question?
Let me just tell you, that was the voice of Matt Bartlett, who's an orthopaedic surgeon and is the clinical lead for the elective orthopaedic centre. Pippa, do you want to put?
Yeah, so what we can see if you look at the total of the PTL, so the patient treatment list for orthopaedics, which counts everything. So this could be complex spinal work. It literally clumps it all together. There has been a total reduction as well, which tells us then that by taking the more low risk cases into the orthopaedic centre means more of the high risk cases have also been treated. What is the other assurance is that by the end of the month just gone, January, the national ask was to have no patients that had waited longer than 65 weeks. We didn't have a single patient in North West London that was an orthopaedic patient in that space anywhere near it. So, and that would not have been the case if we hadn't have done something different like we did with the orthopaedic centre.
Thank you. Any other questions before I come back to Robin? Robin, have another crack.
Thank you. This is a bit technical. It's about the Cerner and FDP systems and the effect they have on feedback to patients after their consultation. And we raised this before, and the papers for this meeting still seem to suggest that the problems, particularly with the FDP, have not been solved. And yesterday in the HSJ, there was a headline talking about the inadequacies of the FDP as a whole, and that was preventing it feeding into national statistics. Isn't it time that something was done about the use of this platform, because patients are in fact not getting some of the letters they need to know what the follow-up to their consultation is? Thank you.
So the FDP is not the platform which discharge summaries come from, actually. So Robin, but out here, I'll talk to you about any specific issues about that. So There are ongoing issues being raised about the FDP, which we look at on a consistent basis. I don't read the HSJ like you, so I haven't seen that headline, but I think we do note that in any system that we use, there are issues, and I do think there is something that says where there are specific issues, absolutely feel free to raise those with us, and we will investigate them. That's what we're here to do. What we want to do is to use any platform actually to ensure that we've got good visibility of all of our patients, that we treat them in turn, and that actually we make the most productive use of our resources. So, for example, the FDP allows us to look at things like the numbers of patients waiting for discharge and things like that, the numbers of patients going into operating theatres and our use of operating theatres. That's how we use that platform. But happy at some stage to talk in more detail about it.
Thanks, Matthew. Just looking in detail at the written question, Robin, I think there are two bits that strike me. So the first is there was definitely an issue with the preoperative assessment for patients going to the elective orthopaedic centre back at the time you've just described, which we then solved. So that was basically, you're quite right. It was the sort of computer says no, and it was sending too many people back. But we've been working hard to sort that bit out. So I think that bit of the FDP actually is working quite well for us. In terms of the pathways discharge to PIFU, which is the main chunk of your question, that's a much more multifaceted issue, and it doesn't actually involve the FDP. So I think that firstly, we are probably sending many more people onto PIFU pathways than we are recording. And part of the issue is that it's such a pain in the neck to record it on Cerner. So, for example, I've been using PIFU to follow up for 20 years, but never called it PIFU to follow up. And suddenly saying to someone that the arrangement you've had with them for 20 years is now suddenly called something new and they need to have a whole new set of literature about it, is slightly discombobulating. So I think there are some implementation issues with that bit of it, but there's also the recording of PIFU on Cerner is more complex to the clinicians than it needs to be, and that's the bit we're working through.
I think it's worth saying from the digital committee point of view, well, firstly, the HSJ article was about challenges that Bristol ICB are having in building a command centre, which I've no idea what their problems are there. That's out with anything that's affecting us. We've delivered value out of the federated data platform. The thing we mostly talked about at the digital committee is the speed of adoption, of moving from some parts of the ICB extracting value from it to making sure that that value is being delivered everywhere, and that is an operational challenge for us, and it's about speed of change and the number of things that are changing simultaneously, and all of those things. But as Leslie said, very happy to have that conversation in more detail. Can I suggest that with the rest of the Brent Patient Voices questions, we either have a separate conversation with you or we send you a note back about them in writing, so it doesn't become a one-to-one dialogue between you and the chief executives, Robin. And in absence of other questions, and at 1:30, I suggest we wrap up the session. Let me thank you once more, those of you who've joined us from our wider public for this meeting, and thank you to the NEDs and to the executives for their contribution. Enjoy the rest of your day. Thank you.